How you
Okay.
holding up?
It's been a week, Alika. It's been a week, but I'm great. I'm
Yeah.
up here in Whitehorse. This is my clinic, one of the rooms in our office here at Lynx Health. So
That's a
yeah, I've
really
been,
nice background.
thank you. Busy, but enjoying it.
Welcome to Health Signals Episode 2, the podcast where healthcare insiders help you understand whether what you're seeing in the news is a signal or a trend in healthcare and beyond. I'm joined by my co-host, Katharine Smart, past president of the Canadian Medical Association and one of 2022's Canada's 100 most powerful women. And I'm Alika Lafontaine, past president of the Canadian Medical Association and Maclean's 2023 top healthcare innovator. How's fires happening in your area right now?
Well, there's no fires right around Whitehorse, but you may have heard that all the telecommunications to the Yukon went down on the weekend, and there was 24 hours with no internet or no cell service.
That is wild.
Yeah, some of it was related to the fires and the impact on the lines coming up into the territory, but yeah, it was really pretty crazy.
We ended up having a couple of days of really heavy smoke. There was a fire that was about 30 kilometers northeast of where we were.
Oh, wow.
So the winds were blowing the opposite way of the city. So if they had turned around, winds bring fire pretty quick. So I think we're lucky to avoid, but Fort McMurray is evacuating now. So
I saw that. Yeah, it's scary this early in the season, and just all these communities are being affected, and what it's going to look like. Don't know.
Yeah, it is a scary new world out there. Maybe before we jump into the news, what kind of feedback have you been getting out with the pod? Because I've had lots of folks write me since episode 1.
Yeah, I have too, actually. And, I think the biggest piece of feedback I've had from people is how much they appreciate what we're talking about, right? Like, especially a lot of colleagues who are in the healthcare system themselves, I think, said to me they found it really validating to hear what they perceive to be a really authentic conversation about the problems, and appreciated that. Because I think, again, but like what we touched on podcast 1, right? People are kind of tired of feeling like people aren't really speaking the truth on these issues. And I think to solve complex problems, right, you've got to name them, you've got to define them. And I think what we're saying is resonating with people.
Let's take our very first story that we're going to discuss here. It's from Andre Picard over at the Globe. We'll put links down in the description of the show, but it's the crisis in healthcare staffing is no secret, so don't try to hide the gruesome data. So I'll read a quick summary and then throw it over to you, Katharine. In it, he talks about Canada's healthcare system suffering from secrecy, exemplified by a recent example of Ontario's refusal to release data on healthcare worker shortages, specifically physician shortages. Despite a request from Global News and public interest, the government withheld the information, claiming it would harm financial interests and negotiations. Evidence already shows severe shortages, making the argument for secrecy dubious in Andre and I think many people's opinion. Transparency is crucial, and the public has a right to know the true state of the healthcare system. You had a chance to read through that article when it first came out. We had some chats back and forth just over text. How did you feel when you first read through that?
I think the main feeling I had was frustration, right? Like, here we go again with the lack of transparency and hiding information from the public, under the guise of the public good. I mean, this makes no sense, right? Like, again, how do you solve a complex problem like human health resources, which we know is one of the major issues plaguing our healthcare system, if the governments aren't even sharing the information they have so that we can try to solve problems together, right? We know Canada does not have enough doctors. We know Canada does not have enough nurses and all sorts of other experts in healthcare. But if we're not going to get honest with the numbers, I don't really know how we create solutions. So, I was not surprised because I think governments retreat into protectionism because they don't want to get called out or they don't want, it to be their fault, even though, again, we know it's no one government's fault. This has taken a long time to get here, but I think that's the reflex. But again, I just think it's the wrong approach to the magnitude of this issue. Secrecy, lack of transparency, lack of data sharing isn't going to get us out of this. And my worry is that as governments sort of circle the wagons to protect themselves, right, that's just getting us further away from solutions. What did you think?
I do have some empathy to political leaders. I mean, obviously running the healthcare system is really expensive. In most systems across the country, you're looking at 40% or more of whatever you're generating as far as income in your budget. And costs are going to rise. We have let our infrastructure not get updated over the past couple of decades. We have had people lagging behind as far as increases in pay. I'd say there's almost been a decade in many parts of the country where people have had 0% or close to 0% increases. You're not even keeping up with the cost of living. And so now that the economy has started to turn around in some provinces, or at least stabilized, we're now moving into this era where, people are feeling like you should catch up. And so, I think the knee-jerk reaction of any government to sit there and say, we need to position ourselves to optimize the negotiation position, across from whoever we're negotiating with. I can understand that. I am a little surprised that they said the quiet part out loud. That's always been something that we know goes on.
Yes.
But political leaders haven't really, said this is what's going on, right? And so that was a bit of a surprise to me. And I think the other part too, and we talked about it in episode 1, this whole idea of gaslightings. Anyone who's receiving care at any place in the country right now knows that there's a shortage of healthcare workers. They know that the reason why they're waiting for hours on end in the emergency room, why they can't get onto surgical wait lists, why they can't see their primary care provider, is because there's not enough of us to go around, not just physicians, but everyone, nurses, allied providers, et cetera, et cetera. So to say, or to attempt to say that that's just not true, I mean, that is another level.
No, I agree. And I think, in my view, I think part of why they're not wanting to release the information is information that came out around that same time, right? That the shortages are actually much worse than people thought, like magnitudes worse. So I'm sure they're very hesitant to really let that information get out there. I mean, I'm sure some of it is around negotiation and fee increases, et cetera. But, I think we know that we're in a scarcity market for talent. So I'm not sure the exact numbers change that much, but I do think the bigger part of it, in my view, is they just don't want people to really know how bad it is because they don't want to have to take responsibility for it. Because, in my view, like I just think we've let this get so out of control that we're not really in a scenario where we're ever going to be able to catch up, right? Like there's no model, I don't think, where we can train enough physicians in any sort of timely way to meet the needs of the population. Like we've just gotten so far behind. And, we're talking about doctors. I think you could say similar things for other healthcare professionals. Look at nursing. We don't have enough nurses. There's a global nursing shortage. So again, it's not like you can just necessarily like look to your neighbor to poach people. But I think what it really means to me is like, we've got to start talking about different solutions if we want to get a grasp on what's going on. And I worry that we're sort of, recirculating the same ideas over and over again, and we're not really having the right conversation, which is like, we're not going to solve this problem just by training more people. Like we need to fundamentally re-examine the way care is delivered in Canada and arguably probably the world. Like I suspect we're not the only country having this problem, but like, how do we get to those important conversations? And that's what I find so frustrating about this stuff is I think it holds us in this deadlock of conversations that are honestly kind of meaningless. And that's not how we're going to get to solutions. So it's frustrating, I think, to not see the kind of political will or leadership or courage to want to dive into this problem that's so important.
But like we've been saying, people know that this is a crisis right now. And I think it obscures the fact that there is funding going into a lot of places. Toronto Metropolitan University just opened up a medical school. You're probably going to see hundreds of millions of dollars pour into training programs across the country when it comes to training doctors and nurses and other allied healthcare providers. And I think what ends up happening for the average Canadian is they hear this happening and then they read other things and then they start to question, is the truth you're telling me as true as the truth you're hiding from me? Right. And I think in some cases, especially the things that are out there and we know are causing problems, we need to be fully transparent. We need to talk about the problems that are really there. And so that kind of takes us to the second story. This comes out of Ontario as well. And this is by Alison Joan with the Canadian Press. The title is No Concern About Diminished Supply of Doctors. Link will be down in the description. Summary is the Ontario Ministry of Health argues that recruitment and retention of doctors are not a major concern during arbitration with the Ontario Medical Association over physician compensation. This stance comes as the OMA warns of over 2 million residents lacking a family doctor and thousands of unfilled physician jobs. Not hundreds, thousands.
Mm-hmm. Yeah. I think it's challenging. Like, one of the big roles of the provincial and territorial medical associations is this, right? It's negotiating compensation for physicians, as well as other sort of programming, and trying to look at provincial and territorial health challenges, and try to think about, like, how do we solve these things together, right? Again, I think what's so interesting here is the polarity of how this was presented, right? You've got the government saying one thing, it's over here, and you've got the Ontario Medical Association saying something else. And you would think you're talking about two completely different situations by how it's being presented, right? And I think often the frustration on the side of the physicians is that what the government's saying is not reflecting their lived reality, right? Mm-hmm. And that's the part that I think really difficult. Is, again, I just think we've got to be able to agree on some basic facts if we want to move forward. And I think when you're looking at things like negotiations and compensation, you've got to be asking yourself the question, like, how does this make things better for patients? How does this improve access? How does this improve well-being of physicians? And are there opportunities to incentivize the things that we need to make those things more appealing, to attract and retain people, so that our services are more robust? But to get to those types of solutions, you've got to know what you're trying to solve, right? So we know, for example, one of our biggest problems across the country is getting people in community-based primary care, family practice. Well, why is that, right? So if we're not, again, trying to co-define why it's unattractive to people, and look at what incentives and what ways of compensating people might make that more attractive, we're not really going to solve that problem, right? Of course, how people are paid is one part, but it's all the other things we talked about in our first episode around the infrastructure of care, the lack of access to the people you need to care for your complex patients, the administrative burden. These are all pieces that are not making these jobs attractive. So we've got to be able to, like, have conversations about that to move forward. And when I was president of the Yukon Medical Association, I never was in that role when we went through a negotiation, because the pandemic happened right in the midst of my presidency. So our cycle of negotiations was deferred because of that, and we just kind of kept going, because obviously looking after people is the most important thing. But I've been around and circulating around those challenges here for some time now. And again, I think often where we're going to do better is when we can agree on what the problems are we're trying to solve together, and how compensation is one of the tools towards solving those problems, and making sure that the solutions aren't creating new problems, right? And again, I think when you look at a lot of provinces, the fee schedules, the different compensation agreements, the contracts, we're just like layering complexity. And it's just really making it hard for people to feel like they're getting anywhere. So I think there's huge opportunities here to kind of change the dialogue around that. But no one wants to really dive into that so much, it seems.
Yeah, no, I totally agree. And I mean, we've both been in crises, right? Working through the pandemic, being health leaders, heading the Canadian Medical Association. I think when you have these big problems and you're talking past each other and then appealing to a third party, which really is what arbitration is. It's, we can't get along. We can't have a conversation. And then let's bring in a third person to kind of tell us what's true. I think that old adage where, if a final deal, everyone's unhappy, that's the best deal you could get. I think that's a terrible way to approach crisis. What you really need is for people to come together and agree on a shared set of facts. And it is disappointing to see a lot of these conversations, not just in Ontario, but across the country, where people are talking past each other instead of with each other. The very last thing we need to do when more than 6 million Canadians can't get access to a family physician, you have people waiting years to get in on surgical backlogs or procedures or other types of needed healthcare interventions, when you have drug shortages across the country, other consumables people can't get access to. We're in a very tenuous situation over the summer where fires can, spring up. Suddenly your access to medical care and where you thought you were going to go in case you had problems is now flipped upside down, and you have to worry about basic needs like finding a roof over your head and being able to afford to feed your family and yourself over however long before you can get back, if you can get back. You need people on opposite sides to sit down and just say, hey, these are the rules that we're going to abide by, and let's just get it done. And I think that was something we really saw in the early parts of the pandemic. People just said, this is an overwhelming crisis. Let's just fix it, right? And I I am sad that those relationships kind of forged in fire, fell apart not soon after, the crisis kind of falling apart. And I think that speaks to, a lack of basic infrastructure in the healthcare system. The fact that we don't have open, transparent data where the average Canadian can look up and go, yeah, there's a family doc within 20 kilometers of, where I live. My wait times will be this long if I go to this emerge instead of visiting, 9 different websites in order to figure that out. It would lead, I think, to different conversations if we had better data, which I think is what Michael Gorman and CBC News with our third article is kind of arguing when he talks about the health minister thinking data could take policies out of healthcare in Nova Scotia. So I'll read that summary real quick. So Nova Scotia's health minister, Michelle Thompson, emphasizes the need to depoliticize healthcare and healthcare decisions, believing it can lead to better, more effective and objective strategies. Speaking at a Halifax Chamber of Commerce event, she noted that more comprehensive data, including race-based information, is needed to inform resource allocation and policy decisions. Thompson highlighted progress in expanding healthcare professional scope of practice and introducing new care pathways like pharmacy clinics and virtual care. Despite a high demand for primary care, the government aims to match patients with health homes, though staffing remains a challenge. Lots packed in there. What's your response?
Yeah, lots in there. I mean, I think the most important thing of all what she's talking about is this idea of trying to depoliticize what's going on, right? Again, I think it's trying to get away from that polarity and also trying to get away from, pointing fingers and that it's one person's problem, and also away a bit from the election cycles, right? Because fundamentally, I think why we're not getting anywhere is, and it comes back to what we were talking about before too, about even the negotiations around compensation, is I think we're not having a lot of the right conversations, right? We have a healthcare system that was designed in a different time for a different population, and we're kind of flogging that dying horse, trying to extract more from it with that same model when things have changed. Like, I mean, what right now in the country is operating in the same way as it did in the 60s or 70s? I mean, literally nothing, but we're still using that model of healthcare to move forward. So I think what she's, saying is like, let's get the data out there. Let's try to agree on a set of what we're trying to do. And let's try to pull back a little bit from it being so political, because that us versus them, good versus bad, that's not going to solve this issue. And that's, really fundamentally what worries me the most. And even when we're talking about things like, contract negotiations, like whether I get an extra $1 for this fee code or 50 cents here, like, is that really fundamentally the problem? Like, no, I mean, the problem is the system is outdated. It's not meeting the needs of where we're at for patients or physicians. And we really need an overhaul. And you hear a lot of language around systems transformation. I mean, what does that mean? I think really what we're trying to say is, the system is outdated. It's not built for purpose. We've evolved past it, and we've got to get into better conversations about what does a real redesign look like. And I think these, sometimes these negotiations, different things that are really down in the weeds with detail, are distracting us from the most important conversation, which is how do we just like recreate this whole world called healthcare. And I think part of that for sure is what she's talking about, which is like, let's just get the data out there. Let's just get the facts, right? Then at least we can start reimagining where we're going. But I think we just keep falling back into these pits of small things, right? Like small manipulations, small changes. And it's never going to get us where we go. We've been tweaking around this system, forever, hoping that we're going to get something different. And I just don't think we are. As I had the opportunity to work with Joe Gallagher at the National Health Fellows, and his one thing he said, which I thought was brilliant, is he's like, we've got this operating system, which is healthcare, and we keep trying to add apps to it, hoping it's going to fix it. What we need is a new operating system. And I love that analogy because, again, I think people get that, right? If your iPhone's dying and you just keep trying to add apps to it, like it doesn't work, right? Like you need a new system. And I think that's really where we are. The operating system fundamentally is not going to meet our needs. We've got to do more than add apps to it. We've got to redesign, and someone's got to have the courage to start that. But I think the data can be a level set so that we can all agree on the facts, as you've been talking about. What is the truth? Let's move from there. But we've got to have different conversations. What did you take from it?
This conversation has me thinking about who actually has control in healthcare, right? And I don't know how you feel about what I'm about to say, but when a patient comes in, and a reminder, I'm an anesthesiologist, so I give drugs for a living, right? So you come to me, I help you forget, I help take away your pain, I help you survive going through surgery. So in a very real way, patients don't really have any control with me. The real choice they have is whether they show up or whether they leave. That's really the control they have. But then me in the system, I have no control over any resources. I'm kind of stuck with whatever they give me. If there's equipment, if there's medications, if stock has run low or other things, I'm like trapped in a different kind of box where I can't control anything. And then politicians, I think, are trapped by voter expectations. And so you have this circle that goes round and round where, the control is never in the hands of the person directly across from you. And I think one of the things that Minister Thompson really argues well in the speech that she gave was, if none of us have control, that's the reason to depoliticize. Governments don't want to be caught in a mess that they more or less have inherited. We experience turnovers in government, but they're experiencing the downsides of decisions that were made over the last 30 years.
Absolutely.
The problems in the healthcare system are not brand new, right? And I think that depoliticization and an agreement that we're going to create data sets where we can point to those and use those to guide our decisions, I think makes a ton of sense. And I think intuitively for most people who'd listen to this conversation, they'd sit back and go, yeah, it actually does make sense. Instead of calling, a third party to make a decision that may or may not have all the evidence, why not just have the evidence and then have folks, critically think through the problems moving forward? Because I agree with you. The ways that the system was set up in the 1950s was really for people who are not mobile and for healthcare providers who stayed at a single place during their entire career.
Yeah.
Right.
And a much younger, much healthier population
100%.
with much simpler problems, right? And a life expectancy in the 60s. It was a different world.
Yeah. And I mean, if you could not walk to the place that you had care, you had no care. That was it.
Yeah.
And I think there were a lot of, rules out there that people practiced, but maybe didn't say out loud, like people did not intervene with the 100-year-old who needed a hip fracture. If a person could not get access to certain care and they had to be shipped halfway across the country for care, it just didn't happen. It was cost restrictive. There was no way to do it. And so the expectations that we have nowadays are so much higher. Patients are so much sicker. Things are much more expensive. But I think our expectations have just gotten higher and higher. You have voters who think that things should be cheap when they can't be. You have politicians who think that they can still convince voters that things can be cheap as everything kind of falls apart. And then you have providers who are still trying to practice in the old system where they work by themselves in silos. They don't want to open up their practice to, other types of team members, although I think that culture is starting to change across the country.
Yeah.
So let me ask you a question then. 3 news stories, all kind of touching on the same topic. What would you communicate to, a close friend who wasn't in healthcare, who wanted to understand what in the world is going on with these 3 stories?
I'd say, I think the really the kind of unifying piece is that healthcare has become a black box. In the black box is the information we need to solve a complex problem. No one wants to open the box because they're afraid of what's going to happen if they do, right? The Pandora's box, so to speak. And that, our job, I think, as citizens is to ask our politicians to have the courage to open the box, get the data out there, and let people start using it to make things different and better, right? But I do think the other thing we have to accept as a society, and you touched on it a bit, is there likely does need to be some hard conversations about what can our fully public healthcare system look like in terms of what level of care is it going to be able to continue to provide for people, right? It's just technology has just outpaced us so aggressively in healthcare that we're able to do so much. Is it realistic to think our healthcare system is going to be able to continue to deliver this level of care all the time for free for everybody? I don't know. I mean, I don't think I have the answers to that, and I don't think they're my answers to give, but I do think they're a conversation that needs to happen in our communities and in our country about where we're going with all this, because there are trade-offs, right? Like right now, we have a system that's very much tipped to the tyranny of the urgent, right? It's very much a rescue style healthcare system, right? If you're really sick, like boom, all this stuff happens. But we are not investing in well-being and wellness. We're not investing in creating health. And many of those types of more preventative interventions are, there's no money going into that. And we're dumping all our money over here when people are already really sick, trying to kind of pull them off the ledge, right? Put them back up on the hill. And I think these are important conversations, because the way I see it is, I just don't think the system as it is now is ever going to actually work. I just don't think the numbers actually make sense. And I think that's what's terrifying about the data, is what it actually makes you have to say out loud is, wow, like the ways we've done things are never going to catch up. I don't care how much money you pour into the system tomorrow, it's never going to catch up. So let's actually start talking about like what does new look like? But that's a dark, scary box for people. And I think as citizens, we've got to be, also part of that, like having the courage to have those conversations. So, I think that to me is kind of the fundamental message there, is we've got to move past just thinking more of the same is a solution. I don't think that it is. And I think that's the deep, dark secret that's in the box.
Yeah. And, to extend that a little bit further, what is the same? We have a sickness system, right? Every time that you have a disease, it's viewed as a battle that you have to win, no matter what you have to sacrifice. And I think we both see folks who come through our care who sometimes make decisions to pursue things that just completely ruin their quality of life in the waning days of how long they'll be around. And I will say that some of the most meaningful conversations I've ever had in medicine have been sitting down with someone who is trying to figure out what decision to make. They're close to end of life. And I just have a really blunt conversation. They can go forward with surgery. Recovery is going to be terrible. You're going to be in pain for the next 3 months. You're not going to regain your mobility, and you have increased risk of a variety of things that could actually kill you. You can make another choice where you don't fix the problem. Things will progress. It will be terminal. But you could at least have, a few months where you can say goodbye to family members and, have a good quality of life, move around without enormous amounts of pain. And I think that living well and dying well is conversations that we don't include in that battle, binary way of looking at things. And, when we talk about not being able to provide care, that doesn't mean that you can't have people thrive. That doesn't mean that they can't be healthy. And as you transfer stuff like we've talked about for the last 10 years to dealing with upstream problems with social deterrence of health and making sure people feel connection in their community so they don't run into as many problems with mental health issues. And, they have increased mobility and better diet. That way they don't develop a host of other medical conditions that later on need intervention. We do have to take from one place and, invest in the other. And I think it's taking money out of the healthcare system and actually putting into people's lives again. But those conversations need to be had so we can create that line, that division, because I think right now it's really blurry. Where does the healthcare system begin and where does it end? I don't think we know that right now.
Oh, no, I agree. And I think we've created an expectation in the healthcare system that regardless of what's going on, we're just going to keep throwing stuff at you, throwing more and more at you, right? And I think that's where some of the data comes, that the most dollars are spent on people in the last couple of weeks of their life in the healthcare system, right? So does this make sense? Are we using our resources well? Are we caring for people well? Are we communicating well with people? Are we even having these conversations? I don't know. But I think these are the types of questions we really need to be asking. And I would love to see a shift in perspective. I don't think we can, continue with a system that's only focused on sickness and illness care and think that this is something that's going to be affordable. I think we've already shown that it isn't. I would love to see a reorientation to health and well-being, thriving populations, but I know that doesn't happen in a hospital. Of course, that type of care is important, but you're never going to create health there. So we've got to shift. And obviously for myself as a pediatrician, that's something I'm really passionate about, because I see how much children and families often are struggling to get basic needs met, the stress that causes and how that impacts children and their development. And we know that all that adversity in childhood directly links to your health and wellness as an adult, both mental but also physical health. So, we know what some of the issues are, but we're just not as invested in those things. And I think it's because they're complicated, right? They're harder to solve. The payback's longer. It's not totally straightforward. So we sort of focus over here on, do we have enough ventilators and ICU beds and all these critical things that are kind of sexier, and not to say they're not important. Of course they're important, but they're not the only thing that's important. And I think we're getting the mix a bit wrong.
Yeah, no, I totally agree. So if you made it to this end of the pod, click like, helps us with the algorithm. Click subscribe, helps us with the algorithm. We're here for the long haul, having these conversations over the coming weeks and months. And just to summarize, this is the way that people start to understand healthcare and what it actually means, because the lessons you take away from the headlines maybe aren't the ones that we should actually be focused on.
Yeah, so, agreed.
Just before we close off, where are you off to over the next week or two?
Well, I'm here in the Yukon, and then I have some board meetings in Toronto, and I'm off to Vancouver for a pediatric meeting. So I've got a few things on the books. How about you?
Oh, excellent. I'll be traveling over to Montreal for a couple of presentations. I'm actually going to be giving the Mannion lecture this year. It's
fantastic.
Yeah, it's one of the keynotes to the Canadian Public Service. So I'll talk a bit about the presidency time over at the CMA and what we can learn about dealing with polycrisis there. You stay safe up there, Catherine. Hopefully the fires don't affect you too much, and hopefully the same down here.
Thanks, Alika. You too. And yeah, to all our listeners, looking forward to being in touch in the next couple of weeks.